a radiopacifier which does not cause any discoloration and a thickening agent. Uses, of course, the root ST, the bioceramic sealer, is used as a permanent root canal filling material in conjunction with gutta-percha, while root PT, the bioceramic putty, is used in vital bulb therapy cases, direct, indirect bulb capping, partial and complete bulbotomy, regeneration, revascularization as a retrofilling material in apical surgery, lateral and focal perforation repair, internal and external root resorption. Of course, nowadays there are so many studies that support the use of bioceramics. Here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealer. In this study, they compared different PC sealers worldwide, and they classified the hydraulic cements according to the percentage of the calcium silicate content in the composition. And they classified the hydraulic cements as follows: low charge, which is lower than 20% of calcium silicate content; medium charge, which is higher than 20 and lower than 40; high charge, which is equal or higher than 40% of calcium silicate content. According to VERICOM's material safety data sheet, where root ST contains from 50 to 60% of calcium silicate content, which is considered the highest among almost all BC sealers worldwide in calcium silicate content. What is hydraulics? Simple hydraulics is the injection of the bioceramic sealer into the root canal system, then applying the master cone gutta-percha to the full working length, which act as a piston that push the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. Here is a lateral canal filled related to upper lateral incisor, a lateral canal filled related to upper canine, two lateral exits filled related to lower first premolar. Here are two lateral canals filled related to upper second premolar. Here is an isthmus area filled related to upper first premolar. Here are lateral canals filled related to upper first premolar. Here is a lateral canal related to a lateral radiolucency in upper first premolar. Here is a lateral canal filled and an apical delta filled related to lower second molar. Here is a lateral canal filled related to the mesial root, and here is a 3-year recall. The lateral canal is still filled with the sealer. The sealer did not wash out, did not resorb. Here is an isthmus area and a lateral canal filled related to the mesial root. Here is a 5-month recall, shows healing, and the lateral canal is still filled with the sealer. Here is a nice microanatomy filled with the sealer. Here is a lateral canal filled related to the palatal root of upper first molar with 4 roots. Here is a tiny loop filled related to the mesiobuccal root, and here is a 3-year recall, shows healing, and the loop is still filled with the sealer. The sealer did not wash out. Upper central incisors. Upper central incisors has more than 40% incidence of accessory canal, and there is a variety of lateral canals. When patency not achieved, what to do? This is a type C lower second molar. I wasn't able to achieve patency, so I injected the sealer and added tapered auxiliaries. After I sealed off the gutta-percha, I got 2 lateral exits filled with the sealer. And here is after 3 months, after indirect composite restoration. In this case also, I wasn't able to achieve patency. After I injected the sealer, I got a nice and bizarre microanatomy filled with the sealer in the mesial and the distal root. In this case also, I wasn't able to achieve patency on the distal root, so I injected the sealer and I got a tortuous lateral exit filled with the sealer. Here also, I wasn't able to achieve patency in the distal root. As you can see, the sealer flows and puff through the tiny apical foramen. In this case also, I wasn't able to achieve patency in the distal root. After I injected the sealer, I got an abrupt 90-degree lateral exit filled with the sealer. Where root ST will help you achieve the optimum apical seal on almost all types of cases, especially the following case scenario. Long roots more than 25 mm, extremely curved roots, multi-planar curvature, S-shaped curvature. In cases of conservative shaping, teeth with external root resorption, compromised roots for strengthening, large periapical lesions as it promotes healing. This canine was 32 millimeter length, multi-planar curvature combined by conservative shaping related to upper first molar, multi-planar curvature combined by conservative shaping related to lower second molar, multi-planar curvature combined by conservative shaping related to lower second molar, extremely curved and long roots upper second molar. This is an upper 7 with tough and severe curvature. Here is a master apical file, and here is the immediate post-obturation using the sealer and gutta-percha. And here is another X-ray view. Separated file retrieval. When we retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics, as bioceramics bonds to dentin and act as a monoblock. As you can see, here is a furcal canal related to the furcal radiolucency filled with the sealer. And here is 1 month recall after crown placement. In this case, I have a large radiolucency and there is a separated file in the mesiobuccal canal. After I retrieved the separated file, the canals were oozing exudate, and I had to finish in one visit, so I injected the sealer and finished the case in one single visit. And here is after 8 months, there is complete healing. The sealer is still the same, did not washed out, did not resorb, which is very tough, by the way. The sealer can be easily washed out by the exudate before its final setting. But thanks to the quality, the sealer did not washed out and it set, and the healing occurred. Here also, after we retrieved the separated file, we compensated the dentin using bioceramics. This is a retreatment case that went from simple to very difficult. During gutta-percha removal, I separated 5 instruments, and one goes beyond the discal apical foramen. I managed to retrieve all 5 instruments and I finished the case. And here is the 1.5-year recall, shows complete healing, and the sealer is still the same, did not washed out, did not resorb. Healing of another large lesion. As you can see, this is a large radiolucency. After 2 years, it's almost completely healed. This is another retreatment case, and here is a 3 months recall, shows significant reduction in radiolucency size, and here is after 1 year, there is complete healing. The sealer still exists, did not washed out, did not resorb, did not prevent the healing. Here is also after 6 months, shows complete healing despite there is a separated file at the mesial root. If you can see, there is a file separated beyond the mesial apical foramen. Here is a 4-year recall, shows healing, and the lateral canal is still filled with the sealer. Just after 8 months, the furcal bone, the furcal radiolucency disappeared. The radiolucency is due to the lateral canal here, causes this radiolucency and massive bone loss in the furcation area. 1.5-year recall shows healing. 10 months recall shows healing. This is a tough retreatment. I did surgical and non-surgical retreatment, and here is immediate post non-surgical and surgical retreatment. This root is filled with the body, and here is after 5 months is a significant reduction in radiolucency size. This is another tough retreatment. The canals were blocked using flowable composite, so it was very hard to find the orifices. But here is immediate post retreatment, and here is after 5 months. It shows significant reduction in radiolucency size, and here's another X-ray view, shows nice microanatomy filled with the sealer, and the patient became completely asymptomatic. In case of limited accessibility and limited mouth opening, this is a lower wisdom with nice microanatomy filled using the sealer. Long-term recalls. When we use a new material, we must and we have to follow up the material as much as we can to see the material, how it will act by the years. So here is a 7-year recall for a tough lower wisdom. The sealer still exists, still the same. Another 7-year recall for lateral and canine. Another 7-year recall, the sealer still exists despite it was a tough calcified case. As you can see, there is no bulb space obvious in the preoperative radiograph. Anyone here practicing vital bulb therapy? Anyone here practicing vital bulb therapy? Vital bulb therapy, direct bulb capping, bulbotomy, no one? Okay. American Association of Endodontists position a statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from trauma, number one, queries, or restorative procedure. Vital bulb therapy procedures have traditionally included indirect or direct bulb capping, partial or complete bulbotomy. We have 5 steps to do to get a successful vital bulb therapy case. Number one, diagnostic consideration for vital bulb therapy. You should have sound diagnosis. The current AEE diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible bulbitis, and irreversible bulbitis. This is number one. You should have sound diagnosis. Number two, caries management. Complete caries removal. Any residual caries left behind will affect the prognosis. So you have to remove all the decay. Number three, use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis and disinfection of the dentine bulb interface. Hemostasis can be achieved within 5 to 10 minutes either via direct passive irrigation or on a sodium hypochlorite soaked cotton pellet. Number four, use of contemporary materials in vital bulb therapy, which is the calcium silicate or the bioceramic material. It has improved barrier quality than calcium hydroxide. Number five, immediate placement of a permanent restorative material. The advantage of immediate restoration is the prevention of the micro leakage, protection of the biomaterial layer, reduction of the postoperative sensitivity and thermal conductivity. So we have to do all 5 steps in one single visit. The primary goal of vital bulb therapy procedure is the creation of optimal conditions for bulb tissue repair and preservation. This paragraph here, a pre-treatment diagnosis of irreversible bulbitis is not necessarily an indication for bulbectomy, as more conservative treatment could be considered. They mean by this, you can do bulbotomy in cases diagnosed with irreversible bulbitis. Okay? Here are the cases. I did direct bulb capping. As you can see, here is the body material inside the bulb horn. After 4 years, the bulb horn returned intact again. So a barrier was formed. The repair occurred. The tooth was completely asymptomatic, responds normally to cold with no any radiographic finding. Here is a 1-year recall after direct bulb capping. As you can see, there is a barrier that was formed. This also was completely asymptomatic. Direct bulb capping for lower second premolar. After 3 years, the tooth was completely asymptomatic. We also did root canal treatment to the lower first molar as it was necrotic. And here is a 2-year recall, shows complete healing. Direct bulb capping for upper first molar. And here is a 3-year recall showing barrier formation. This was also completely asymptomatic. Even in the aesthetic zone, the anterior teeth, we can do vital bulb therapy, direct bulb capping, bulbotomy. Here is a tiny exposure, capped with the body material, immediate post-restoration, immediate post-X-ray. As you can see, the body can be easily detected because it's highly radio-opaque. You can see it easily in the X-ray. Here I did direct bulb capping for upper central incisor, and here is a 1-year recall, shows narrowing in the bulb chamber indicating barrier formation. And here is 1-year recall clinical image. There is no discoloration occurred in the central. This is another trauma case. I did complete bulbotomy for upper central incisor. Even in cases diagnosed with external cervical resorption, I was able to do complete bulbotomy. I bought the capping material, the BC body, and there is immediate post restoration. And here is 1 month recall, shows nice tissue healing, and the tooth was completely asymptomatic. This is another trauma case, came like this, with 2 exposed upper centrals. Incomplete maturation of post roots. I did complete bulbotomy, and here is 10 months recall, shows complete maturation of post roots, and there is no discoloration occurred in the central, so you are free to use this material in the aesthetic zone with no fear of discoloration. It won't discolor the tooth at all. Unlike most MTA brands that causes massive discoloration, even the white MTA causes massive discoloration. Direct bulb capping for lower second molar. Here is the 3-year recall showing barrier formation. Here is the barrier that was formed. Look at the red arrow pointing at the barrier. Look at the difference. Here also we did direct bulb capping. Here is the 1.5-year recall. Here is the 4-year recall. The tooth was completely asymptomatic with no any radiographic finding. Okay. Here is a 50 years old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be the treatment plan here, knowing that the first molar is completely asymptomatic? Simply, I did root canal treatment to the lower second molar as the bulb was unhealthy and have to be removed. It was oozing blood, uncontrolled bleeding, so I did complete bulbectomy, root canal treatment. While I did direct bulb capping to the lower first molar as the bulb was healthy and could be kept alive, so I did direct bulb capping. And here is the 1-year recall. The tooth was completely asymptomatic. And here is the 2-year recall shows barrier formation. There is a barrier that was formed. And here is the red arrow pointing at the barrier that was formed after 2 years. Direct bulb capping for upper first premolar. Partial bulbotomy for lower first premolar. And here is the 1-year recall showing narrowing in the bulb chamber indicating barrier formation. And the tooth, of course, was completely asymptomatic. Complete bulbotomy for upper second premolar. Partial bulbotomy for upper first molar. Partial bulbotomy for upper first molar. Partial bulbotomy for lower second molar. Partial bulbotomy for lower second molar. Even in cases with bulb polyp, here is a bulb polyp, I was able to do partial bulbotomy. Here is the immediate post restoration. 2 days after, the patient reported completely asymptomatic. Partial bulbotomy in lower first molar. In this case here, I had 2 exposures, but non-bleeding exposures. I cannot do direct bulb capping. I have to enlarge the exposure site to a partial bulbotomy site or maybe a complete bulbotomy site to check the attachment and see if there is a bleeding, if it's a necrotic or healthy bulb. So after I enlarged the exposure site, I found it healthy. I have bleeding. I stopped it, so I did partial bulbotomy, and here is the immediate post restoration and X-ray. Complete bulbotomy for upper first molar. Even in deep caries lesion, I was able to do partial bulbotomy in this upper first molar. Even in fractured cusps, I had a fractured mesiolingual cusp. There is, of course, exposure, so I did build this margin and I did complete bulbotomy. And here is immediate post bulbotomy, and here is 1-year recall. The tooth was completely asymptomatic. Starting from this case, the diagnosis is irreversible bulbitis. All patients came with symptoms of irreversible bulbitis. As you can see, there is a dark red profuse bleeding. After I removed the whole coronal bulb tissue, I did complete bulbotomy. I was able to do complete bulbotomy. Here is a capping material and post restoration and X-ray. This case also is diagnosed with irreversible bulbitis. I did complete bulbotomy. Here also, complete bulbotomy for lower first molar, diagnosed with irreversible bulbitis. Complete bulbotomy for lower first molar with irreversible bulbitis. Even in cases with bulb stone, I have a detached bulb stone. I removed it. I was able to achieve hemostasis, check the bulb attachment. I was able to do complete bulbotomy, and here is the immediate post restoration. This patient here came with severe pain. I struggled to get this pinpoint exposure. I gave him intrabulbar anesthesia. Then I did also partial bulbotomy, and I did capped the exposed bulb. I did my restoration. 2 days after, the patient reported completely asymptomatic. Complete bulbotomy for upper first premolar. Root canal treatment and vital bulb therapy in the same tooth. Can we do that? Can we do root canal treatment and vital bulb therapy in one tooth? Let's find out. Here is a 9-year-old boy who came complaining severe pain that awakes related to his lower first molar. Upon taking a radiograph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. Upon exposure, dark red profuse bleeding came out with little amount of pus. Pus came out in this case. After axing the tooth, dark red profuse bleeding came out. Here is our trials to control the bleeding. I want to see where the blood comes from. I cannot see. This image told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I did cap the distal bulb using the putty, and I did root canal treatment to the mesial root. Here is a confit X-ray, and here is immediate post-obturation and capping using the sealer and the putty. And here is the X-ray on the left is 18 days recall. The X-ray on the right is 1 month recall after stainless steel crown placement. The boy was completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. And here is the 14 months recall shows complete maturation of the distal root. This means that the distal bulb stayed alive and continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious exposure, retrospective study. Success of direct bulb capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during carious tissue removal. 1 year follow-up, randomized control trial. Conclusion, teeth with carious bulb exposures and reversible bulbitis can be treated successfully. US direct bulb capping MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and meta-analysis, Journal of Endodontics 2015. Direct bulb capping with calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less bulbal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, a novel bulb capping agent, the bioceramic putty you are using here. The pre-mixed bioceramic materials possesses favorable results and all the properties comparable to the currently recommended material for bulb capping, MTA. The results are comparable or even superior. Starting from this study, it's about vital bulb therapy and irreversible bulbitis. Bulbotomy of symptomatic permanent teeth with carious exposure using mineral oxide aggregate. Conclusion, bulbotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Success of coronal bulbotomy in permanent teeth with irreversible bulbitis. An evidence-based review. Coronal bulbotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients in teeth with irreversible bulbitis as a substitute to root canal therapy. Vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbitis, reports with long-term controls. Vital bulb therapy with partial or total bulbotomies using bioceramics under aseptic conditions, rubber dam, is a viable treatment that will have long-term success in permanent teeth with irreversible bulbitis when indicated correctly. Again, vital bulb therapy for permanent teeth with diagnosis of irreversible bulbitis, biological basis and outcome from a bulb biology perspective and based on data from clinical trials. Partial and full bulbotomy using calcium silicate cements are successful treatment modalities for teeth with carious bulb exposure and symptoms indicative of irreversible bulbitis. Remember, The best root canal treatment is the one you can avoid, and the best obturation material is what God's created, which is the dental bulb. We can use the body also as a root canal filling material. Here, after I retreated the lower second molar, I filled the whole distal root using the body. I did this case 6 years ago. 2 years after, the patient came complaining severe pain related to the tooth. After I took a radiograph, I found a radiolucency related to the distal root only. So I retreated the distal root only and I filled using the body material. 2 days after, she reported completely asymptomatic, and here is the clinical research that supports the procedure: selective root retreatment, a novel approach. In this case also, this is a female colleague, came complaining severe pain related to her lower first molar. Upon taking a radiograph, I found a massive radiolucency related to her lower first molar, the distal root only. So I retreated the distal root and then filled using the body. And here is after 1 month, shows significant reduction in radiolucency size despite the overextended getapercha. Even in trauma cases, this is a necrotic upper central incisor, so I did full root canal system obturation using the body material. This is another trauma case where I filled the whole root canal system using the body material. There is no fear from the extrusion, despite you should take care from extrusion near any vital structure. This is a massively destructed upper central incisor. As you can see, I did apical plug using the body, then 2 fiber posts to build the tooth. Here also, after I removed the overextended getapercha, I did apical plug using the body material. And here also, the large root canal system in the mesial and the distal was filled using the body. And here is in the shifted X-ray view, the body filled the system perfectly. Hydraulics power. Bioceramics are a real savior and a game changer material. How? How bioceramics changes our daily practice? Perforation repair. This is a case of upper first molar with huge perforation repaired using the body, and there is immediate post-repair and retreatment. And here is a 5 months recall, shows significant healing. I did this case 6 years ago. I repaired this perforation using the body, despite I was able to repair using the composite resin, but I can follow up the case, so I filled it and repaired using the body. And here is after 4 years, the body is still the same, despite the composite as the distal margin was ditched. So the body survived. The body can be easily washed out in this area. It is subjected to the oral cavity environment. This is also a referred case from a colleague for perforation repair. Here is a file in the perforation site. Here is a perforation site periphery. After detection of the missed canal, immediate post-obturation repair using the body. And here is immediate post-obturation and perforation repair using the sealer and the body. And here is after 1.5 year recall, shows healing, and the patient, of course, was completely asymptomatic. External root resorption. This is a female colleague who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a massive radiolucency related to a massive external root resorption related to the distal root. We decided to give the tooth one more chance, so we retreated the tooth. Here is a large H file in the resorptive defect. I decided to obturate the mesial root first because the distal root was oozing blood and exudate. So I blocked it using Teflon and I obturated the mesial root first. Then I did the same in the distal root. And here is the immediate post-obturation using the sealer. Despite the heavy extrusion, here is the 4 months recall. The sealer did not wash out, did not resorb, and it's for 100% it's completely set. And there is nice healing after 4 months. And here is 8 months recall, shows more healing, and the sealer is still the same, did not wash out, did not resorb. And here is a conclusion from a study that was comparing different PC sealers worldwide. They found that Root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the surface. Here is a day 0, 4 months recall, 8 months recall, 2 years recall. There is a complete healing, and the sealer still the same. Did not washed out, did not resorb, did not prevent the healing. Intentional replantation and the crack management. I did this case in 2013. I did direct pulp capping to the lower first molar using dical. In 2017, symptomatic apical periodontitis started to appear. We did root canal treatment. In 2019, the tooth almost completely healed. Unfortunately, in 2021, a horizontal crack pattern started to appear, like a half circle here. This is an indication for a horizontal crack pattern. After I accessed the tooth, I found the crack site, and here is a methylene blue dye staining the crack. We decided to give the tooth one more chance. I removed all the gutta-percha and I filled the whole root canal system using the body material. Unfortunately, the patient still have symptoms. So I extracted the tooth, cut the apical part of both roots, and put back again into the socket. And here is the immediate post-replantation X-ray and clinically. And here is the 3 months recall, shows significant healing, and the patient, of course, was completely asymptomatic. This is a referred case from a colleague for a separated file in a dilacerated mesiolingual canal of lower second molar. I wasn't able to neither bypass nor retrieve the separated files, so I extracted the tooth, cut the apical part, filled with the body, then put back again into the socket. The patient became completely asymptomatic. Deep split management for non-microscopic clinicians. Here a case of upper second premolar with Vertuschi type 7. Vertuschi type 7 has the anatomy of 1, 2, 1, 2. Let me tell you some tips and tricks to manage such anatomy. Number 1, stick to the reference point, buccal cusp, palatal cusp. Number 2, recurve all your instruments, your hand files, your rotary files. Number 2, shape both canals together. And what I mean by shaping both canals together, when you start shaping the buccal canal, for instance, with 2004, you do the same for the palatal, 2004. 2504 for the buccal, 2504 for the palatal. 3004 for the buccal, 3004 for the palatal. Why? Because if you shaped one canal to the master apical file, every time you put the file to start shaping the narrow, the unshaped canal, the file will tend to enter to the larger one. So you will find difficulty to enter to the narrow canal. It hits like a wall. You are hitting in a wall. So that's what I meant by shaping both canals together. And of course, sonic activation and polymer needles for disinfection and activation. And of course, hydraulic condensation, inject your sealer, put your gutta-percha cones, and you're done. Another Vertuschi type 7 with the same anatomy 1, 2, 1, 2. The problem always in here. In the one part apically, you almost feel like you're hitting in a wall. So you have to recurve all your instruments. Another Vertuschi type 7, upper second premolar, has the same anatomy 1, 2, 1, 2. Another level of splitting with buccal and lingual canals with nice anatomy, lateral canal filled. Lower first premolar with buccal and lingual canals. Okay, this is another difficult level of splitting, also did without the microscope, with the tactile sensation and the X-ray, of course. From the preoperative radiograph, it was clear that we have one main canal, and here are two tiny splits. It's quite obvious. Now I will put my file, take an X-ray. I just one split detected. Okay. More files, more X-ray, one split in the main canal. Now the two splits were detected. Two splits were detected. How I will obturate these tiny splits, I cannot see, I cannot fully shape. What I'm gonna do? I tried to make gutta-percha harder. So I recurve it, put an ice cube, sprayed with an endo ice to make it more stiff so I can introduce it in the tiny splits, but I failed. I couldn't do this. So I decided to depend on another strategy, which is the hydraulics power of the bioceramic sealer. I chose the largest gutta-percha cone that gives me the toughest tuckback. This gutta-percha cone here was 4506. Okay. Then I down back the cone till the level of the splits. So I blocked the main canal first. After that, I injected the sealer and added the rest of the cone. As you can see, the tiny splits are getting filled with the sealer, and a tiny lateral canal started to appear. I wasn't aware of its existence. After that, I added more sealer, more tapered auxiliaries to give more hydraulics, more power to the sealer to flow more. And this is the X-ray. After I seared off the gutta-percha and I did some coronal compaction, I got heavily filled and buffed splits with the sealer. Another splitting in lower second premolar. During a scouting trial, I found 3 splits were detected in the radiograph. Here is a master apical file. Unfortunately, I broke a file in one of the splits. I tried to bypass. It was a very tough bypass, by the way, but I wasn't able to fully bypass the separated instrument. So I decided to depend on the hydraulics. Here is a confit X-ray, and here is the immediate post-obturation. The sealer penetrated beyond the separated file. And there is immediate post-obturation for lower first and second premolar. Another splitting for lower second premolar. As you can see, the internal anatomy was revealed by the sealer. Here is the different X-ray views. Our last case. Here is a case of lower first premolar that was a part of a bridge with multiple splits. I don't know how many. So I put my files. Here are 2 splits were detected, 3 splits were detected, 4 splits were detected. Here is the master apical file for the splits, confit X-ray, and here is the immediate post-obturation using the sealer and the gutta-percha. And here is a quote from my mentor, Dr. Alan Nasih: if you're always worried about failure, you will never reach out for success. Thank you so much, ladies and gentlemen. I hope you enjoyed the presentation. Thank you so much. Any questions are more than welcome. Any questions؟ حد ينفعنا طيب؟ تعال. Sure.
Oh, thank you. No, no, no.
Okay.
Thank you, Dr. Mina.
Thank you, James.
Open apex. This is probably not related, but I want to ask. If it has an open apex, okay?
Mhm.